come to collect you for your surgery, is that okay?
Right.
In the UK, some 3 million major operations are carried out every year.
Nice big deep breath. We'll look after you, don't worry.
Only the country's top surgeons are skilled enough to take on the most critical cases.
Cameron, you all right?
Just take a couple of deep breaths.
If you're going to make a hole in someone, you better be sure what you're going to do.
Should we go for it? Right.
They're using pioneering techniques to treat conditions that used to kill.
A few years ago, these operations were felt to be too big or too dangerous.
But pushing the boundaries of modern medicine comes with great risk.
Just keep quiet for a second, please. If I move the blade too much, she's going to wake up unable to breathe.
Life is precious. It can vanish in a heartbeat.
Whoa!
You need to keep your head. Hold this. The heart is empty. We haven't got any volume at the top. If you panic, the patient can bleed to death.
The surgeons bear the ultimate responsibility.
I need it ASAP. I can't wait for this.
I'm not infallible. Failure is absolutely possible.
We are a team, but there's one person's name at the top of the bed.
Bloody hell.
This is what really happens behind the closed doors of their operating theatres.
This is a battle, us versus the Grim Reaper. And we're not going to lose.
Life is fragile. Sometimes it hangs by a thread. It can change for anybody in an instant.
The Queen Elizabeth Hospital Birmingham treats some of the most complex trauma cases from across the West Midlands.
Hello, I'd like to put out an adult trauma call arriving by land to A&E recess.
With 9,000 emergency patients arriving here every month, each of the hospital's 140 consultant surgeons must regularly be on call. Neurosurgeon Ismail Ugradar sometimes has just minutes' notice before he must operate to save a trauma patient's life.
I'm on call 1 in 8 days. It can be quite unpredictable, so really quite exciting, but at the same time quite harrowing as well, because you can see some really serious traumatic brain injury.
Okay, so we've got a 64-year-old lady who has fallen backwards and sustained a head injury, not moving right side.
Bleeding has now stopped and kind of clotted. She does have full sensation in the limbs and didn't have any C-spine concerns initially. Within 10 minutes on the back of the ambulance, condition deteriorated. She can't lift her right arm, she can't lift her right leg.
30 minutes ago, 64-year-old Susan fell in the street. She has a possible fractured skull, and medics are concerned that she may be suffering a bleed on her brain. Within 11 minutes of her arrival, a call has gone out to neurosurgeon Ish.
There is a bit of adrenaline rush when you get that phone call about something that you think you can salvage just by going in and doing an operation very quickly.
No wound in the groins, no bleeding down there in the cranium.
Sue, open your eyes, please.
So right pupil is size 5.
Patients with head injuries can deteriorate rapidly and are at risk of permanent disability or death.
Head and neck, please.
Head and neck.
Yeah.
Susan is taken for an urgent CT scan to determine the extent of her injury.
It's a significant bleed.
She has a life-threatening bleed on her brain called an extradural hematoma.
Move, ready, set, move.
The area between the inner surface of Susan's skull and the outer protective layer of her brain, the dura, is filling with blood. The space will continue to fill, putting extreme pressure on her brain that could kill her, unless they can open up the skull in time.
Where you've got a clot that's expanding And that has to come out straight away. No two ways about it. The brain cannot take that kind of pressure for a sustained amount of time.
Only an emergency craniotomy, opening up the skull, will save Susan's life.
There's a completely different pace with emergency work. And that's very different to a planned elective practice. Make a decision, get on with it, do something about it. That is trauma neurosurgery, defined.
Susan is taken to be prepared for surgery in Emergency Neurotheatre 21.
Your skull is a fixed box. Your brain's got nowhere to go. It's just getting more and more squished. If left untreated, then she would probably very quickly pass away.
We don't know any history for her. There's nothing on the system. So. Drill somewhere.
While the team get ready for surgery, Susan takes a turn for the worse.
She was all right when she came in, but then her pupils blew. That's why we were rushing. So the pressure in the brain is extremely high.
Her blown pupil indicates the bleed is expanding to a critical point.
Okay, let's have everything. We've only got minutes to get that skull open, that clot out. So every second counts. Somebody tie me up, please.
To release the pressure on Susan's brain, they're going to have to open her skull 3 times faster than they normally would for an elective case. They only have minutes to get through one of the toughest bones in the human body.
A knife, please, starting. I just need a knife and a drill, that's all I need. All the way. Priority is just to get that skull off as quickly as possible. I want to be there within 10 minutes to try and obtain the best outcome for that patient. There's a fracture there, the fracture there. Yeah.
As they peel back the skin, the full force of the impact is becoming more apparent.
You see it's very swollen and it's got a laceration there, so I suspect she's had a direct injury on this side where she fell. Got the drill connected? Yeah, go for it.
To get to the clot, Ish and his registrar Ben Fisher need to remove a 12cm squared section of skull known as a trapdoor.
What you need to do, drill a few holes, use a jigsaw type drill and have the bone off. Thank you. You do release a little bit of pressure with that first hole, but it's not until you take that bone off does the pressure suddenly come off.
Change to cutting.
Having drilled 3 burr holes, Ben uses a specialist saw to cut out the section of skull at the point of impact, gaining access to the clot beneath.
So go around the fracture if you can.
So far, they've been operating for 7 minutes.
If you're not careful with your landmarks, for example, if you cut through a major vein, that can cause torrential bleeding. So you need to be careful where you're going. There you go.
8 minutes since they began, the clot is exposed, and the pressure on Susan's brain is relieved.
Once you've got the bone off, you're happier because suddenly your brain's got room to expand. The skull of that box has been opened properly. And then you see that big clot underneath it. And then that's satisfaction.
Susan is out of immediate danger, but the clot could return unless Ish replaces the trapdoor in her skull carefully, so blood can't build up again beneath.
The skin of the brain at this point now is quite loose and lax. So what you don't want is to put the bone back on, and then the skin of the brain is underneath it, and there's a gap between the two for any small bits of oozing to form, reaccumulate a clot. So what you do is you make lots of holes. We then stitch the skin of the brain and pull it up through those holes. They're called hitch stitches.
And then we just be careful, because if you will strip the meningeal away. Just a bit oozy around it.
So what you do is you hitch and fix the skin of the brain to the bone all round, and then put the bone back on.
Do you want to reconstruct the bone?
Some mini plates and screws, please. Careful, do it here. Okay, that's the fracture through there, so fell straight backwards.
Your brain is basically you, it defines you. It's got your personality, your memory, your movement, your senses, everything. And we know that an operation perhaps is going to change you in some way. Although you may have removed the actual clot, what you don't know is if there is a damage to the internal structure of the brain.
Right, what's going on here?
It's definitely the right way, isn't it?
Yeah.
At the back of your mind, you're always thinking, you know, was it quick enough?
One big wash.
There could be a number of bad outcomes for Susan.
Her scalp here is quite swollen, so sorry.
For example, she lost too much blood, her brain stopped her heart from beating, or coma.
Head bandage, please.
They're all disastrous situations, to be honest.
As well as receiving trauma patients from across the region, the QE is the UK's base for receiving all military casualties from overseas.
Right, morning everybody. Sorry for the late, slightly late.
Good morning.
The hospital's major trauma service has a unique mix of both military and NHS staff who perform emergency operations and coordinate patients' care from arrival to rehabilitation.
He had no exit wound we could find, but he had a load of blood around his mouth that we could not explain, so we ended up looking for the bullet.
My training was greatly enhanced by being in the military in Iraq and Afghanistan. We saw injuries that you would never wish to see outside a battlefield.
Catherine Powell is a commander in the Royal Navy. With many years' experience operating on major trauma injuries.
I enjoy the specialty of trauma surgery. It can be incredibly dynamic and incredibly fast-moving, and things can happen so quickly, as opposed to an elective theatre. You know, that's a very, very different environment. Didn't have as much adrenaline in that one.
A&E at the QE. And what's your ETA?
A motorcyclist has been involved in a high-speed crash and is being brought in by air from over 50 miles away.
Can you get the theatre team ready, please?
He has been classified as a polytrauma patient, meaning he has at least 2 severe injuries. Specialist surgical intervention could be essential. The trauma team will need to work out which injuries most urgently require surgery and which can be more safely operated on later once he is stable.
Stephen. You just arrived in the hospital, okay? So this is Stephen, 56-year-old male, motorcyclist. We presume he's come around the bend, has hit the curb and gone flying.
Okay.
On crew arrival, complaining a lot of pain. His right arm abducted and the left arm looking deformed. Abrasions across his abdomen, but not complaining of any pain. So at the moment, we have got really effectively 2 upper limb injuries that I expect to come out, and his arm's gone backwards like that. Okay. Just quite quickly the arm now.
Stephen has a dislocated shoulder on one side and may have broken his other arm.
Can you do this with your right hand?
Although these injuries are causing him intense pain, the team are anxious they could be what's known as distracting injuries, masking a more dangerous trauma.
Right. Look, with the arm, I know that's obviously what's causing the most pain at the moment. We just need to make sure you haven't got any more serious injuries.
Because Stephen has come off his motorbike at speed, it's possible he has life-threatening injuries to his internal organs.
Any pain in your tummy? Is your tummy sore, Steve? There's some abrasions over his abdomen. Can you feel me touching you here? No. No? Where am I touching you now?
I don't know.
You don't know, you can't feel anything?
Can't feel me right side.
Okay. Right upper limb is cool to touch. Okay. I'm going to take you for a scan to check that you've got no major injuries, okay?
Time is an essence. Scan is ready for the patient.
To try and work out which of Stephen's injuries are distracting and which need the most urgent treatment, the team take him for a CT scan. It confirms that Stephen has a badly dislocated right shoulder, which is restricting circulation in his right arm. He also has multiple fractures to his left arm, and he has a further injury, one he can't feel to complain about, a potentially life-threatening internal bleed near his liver.
It looks like it's going to be a bit tricky. I'm a bit concerned.
Stephen's fractured left arm is a serious but distracting injury. Surgery on this can wait.
Right, on move, ready, steady, move.
More concerning is the dislocated right shoulder that's cutting off blood supply. If not treated soon, Stephen could lose his arm.
He's got quite a significant bleed, so we have to start thinking about limb-threatening versus life-threatening.
Absolutely.
But the internal bleed could be the most dangerous or even fatal injury. Deciding what to treat first is a dilemma for the trauma team.
Hi. Just a bit of an update. So this guy's got a liver laceration that they think is going to require angiography.
An urgent request goes out to the on-call surgeons.
And actually he's got quite a significant bleed in his abdomen, so both need tackling in quite a short time. I don't think this is going to be straightforward. And I also don't think we're not going to have a lot of shots at it. The general surgeons are on the way down.
He's come off his motorbike at high speed. He's got a dislocation of his arm with no pulse, but he's not stable. Okay, I'm on my way. Your senses are awake. That's the drive of adrenaline.
Okay, what's happening?
Anaesthetists and surgeons specialising in liver, orthopedic, vascular and abdominal procedures assemble in recess to discuss how best to approach Stephen's multiple injuries.
To sum up, he has got shoulder injury, vascular injury, liver laceration, so we need to make a decision about whether that requires any further intervention.
I'm personally not convinced it's an active bleed.
Blood pressure is dropping from 120 to 80.
But as Stephen's blood pressure is starting to drop, the decision about whether to take him to theatre becomes more critical.
What I think we should do is get him upstairs, put him asleep upstairs, get his shoulder back in, and then we can reassess from there. But let's get him upstairs, I think. As soon as things change, then I just don't want the patient in the emergency department. I want them in a space where I'm very comfortable.
Shall we take him to theatre and make all the decisions in theatre?
Well, I think we should just go once they're ready. Hi, it's Catherine. Can you tell there's a patient on its way, okay? Everything needs to happen up there, not down here.
Catherine and the team take Stephen to one of the QE's dedicated emergency operating theatres, 17.
Do anything else about him now?
No, I'll try and figure out a bit more from the crew, but there we go. So far, no more stories. Thank you. Cheers. I'll go down to the radiology to find out a bit more.
Okay.
Thanks.
just listen up for 2 minutes, just so we know what's happening? He's got a flush at the back of his liver, but I'm not convinced, okay? So he may end up having a laparotomy, but that's the may at the moment. This is the priority.
By the time Stephen is in theatre, his blood pressure has stabilised again, a sign that for now, his internal bleeding is under control. This makes saving his arm by correcting his dislocated shoulder the top priority.
So the plan is to bring him in, put him asleep, and put this back in place.
A team of 20 surgical staff are ready to treat Stephen's injuries.
Keep moving, keep walking, or don't stop. Right, there's too many people around here, man. Keep walking. Sorry, sir.
We're going to get you asleep and get your arm sorted. All right.
We've got to get that shoulder back into place to see whether or not the blood flow is going to return or not. The longer you leave that, then that becomes limb threatening.
How long is now?
4 hours.
So normally how much time we have?
6 hours.
It's down to consultant surgeon Socrates Kalagriantis, who specialises in shoulders, to save Stephen's arm.
So he needs to have good muscle relaxation, yeah? Loads of, otherwise this won't go back in.
I'll give him a full dose of
relaxation for an hour, so
he should be well. We're going to intubate now, so we can have some quiet, please.
Until they can manipulate his arm back into position, the circulation cannot return.
Pull, 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 pull.
Socrates uses the traction-counter-traction manoeuvre to pull the shoulder back into the joint.
X-ray. Okay, let's have a look. Give me another view. And again. He has a small fracture there, okay? But it's in. That's fine, thanks very much.
Are we in?
Yeah, it's in and looks much better.
A Doppler machine confirms that his circulation has returned.
You happy?
We're happy with the blood supply,
Yeah.
The limb-threatening dislocation is resolved, but Stephen's case remains complex and uncertain.
Still have a feel of his belly. He's definitely getting bigger abdomen. No, you're right, he's a lot more tense.
An unusually firm abdomen could indicate that Stephen's internal bleeding has restarted. The only way to stop it will be to open him up and find the source.
You have bleeding from an arm, well, I can put a tourniquet around that, I can put a bandage around that arm to stop that bleeding. If you've got bleeding from a liver, well, we need to do something to stop that.
He's just sagging again, okay.
If you've got catastrophic bleeding, that will kill you, and hemorrhage and trauma is the biggest killer.
Is there anything else that needs to be said amongst that?
He's type 1 diabetic. He's got end-stage renal failure.
As Catherine and the team continue to assess Stephen's condition, they receive alarming news from his family of a complicated medical history.
He's had 2 failed kidney transplants and a failed pancreas transplant.
He's on warfarin for a previous blood clot in the neck.
Right. Oh, dear.
Stephen's previous failed transplants and the fact that he takes the blood-thinning medication warfarin mean that opening him up will bring significantly higher risks than operating on a healthier patient.
I'll speak to radiology.
Warfarin thins your blood, so it takes longer to clot than somebody who's not on that drug. So when you're injured, it becomes a real problem because you will bleed twice as much as everybody else will, or more.
Because he's had so much surgery, he's not a straightforward, oh, let's just have a little peep inside his tummy type candidate. He could be very challenging.
Doing a big operation on somebody that's had major abdominal surgery before, I'm not wanting to rush into this.
I think I'd rather rescan him rather than rushing in unless we've no choice. That's my instinct to say that.
The big decision in surgery is actually when not to operate. I don't want to put somebody through an operation they don't have to. But the worst thing is I don't want to not do an operation at the right time. There is always some degree of self-doubt.
Just 2 hours after 64-year-old Susan fell near her home, neurosurgeon Ismail Ugradar and his team are completing her emergency craniotomy in Theatre 21.
You've got something to wash your hair with?
With trauma, as soon as that drape goes on, all you can see is a small part of that human being. But then once you've controlled that, taken the clot out, taken control of the situation, then you start thinking, hang on, there's a human underlying this. Are they going to wake up? If they are, how are they going to wake up? So that does kick in afterwards, and you suddenly go back into that mode of, hang on, that's a patient, that's somebody's loved one.
Ish and the team won't be able to assess Susan's condition until they wake her.
Susan, open your eyes for us.
The worry is, has the clot reaccumulated, or has there been other injuries that we've missed that is causing this reduced conscious level? That's the worry immediately.
Susan, open your eyes for us. Susan. Susan, open your eyes for us.
Despite their efforts, Susan remains unresponsive.
Yeah, I'm just wondering, is it worth travelling to CT? Her pressure's extremely low, so we just want to make sure. Let's do a scan, that's right. Spence, let's go. You see a lot of serious head injury patients that never come around or may lose important function, memory, cognitive function, speech, movements, etc. And that's where the real damage occurs.
The scan confirms the procedure has been a technical success. But Susan's recovery is far from certain.
Post-op scan can be quite useful to tell you things are going in the right direction. But there's no real indication what's going to happen in the future.
Ish may have saved Susan's life, but he'll have to wait to see whether her brain can still function fully.
Unfortunately, she had a very severe traumatic brain injury. Occasionally we may do an operation thinking, I'm not sure how effective it's going to be, but we'll give it a go, see what happens, see how they wake up. And yes, if they do well, then you've made the right decision, but if they don't, then you have to kind of live with that consequence.
It may be weeks or even months until Susan's outcome becomes clear. General Surgeon Catherine Powell is monitoring polytrauma patient Stephen in Theatre 17. She's concerned that he is still bleeding internally.
Oh, please tell me that's not his pressure.
A drop in blood pressure suggests it could be getting worse.
He's changing. He's not maintaining his blood pressure. And I have seen blood pressures change, as any trauma surgeon will have. They can change very quickly.
Given Stephen's complex medical history, Catherine needs to be sure she's making the right decision before committing to surgery.
Can I get in here for a minute?
She decides to order an echo ultrasound scan to check his heart and abdomen.
I want to see what this is doing before I'm operating.
Okay, so finding the heart. So, where's Catherine? Is Catherine able to see this? Catherine, can I just show you this?
Yeah, sure.
So what I'm seeing, this is an enormous amount of hemorrhage within the abdomen. Here. I'm just seeing this pool of blood, all of this black stuff there. That is a large clot surrounded by blood within the abdomen.
Yeah. I think we just go. I'm now taking the decision to operate, because then I'm back in control again. If there is something ongoing bleeding, I can deal with that, rather than delaying and let him bleed more and more. I think, guys, we're going to be heading to laparotomy.
Performing a laparotomy means opening up the entire abdomen, from diaphragm to pelvis. It's a major operation bringing risks of infection if the digestive organs are accidentally perforated.
Hi, John. I'm actually just about to open him, I think. He's just gone really saggy on me, and so I'm just going to offer him.
Stephen's blood-thinning medication increases the risk of significant bleeding. So Catherine needs to give herself the best possible chance of stemming blood loss.
Should we just get some blood into him? Can we ring blood bank? I want FFP is what I need, as well as blood, okay? I can't wait for this.
Sorry, I told her 18, didn't I?
Fresh frozen plasma, or FFP, is a blood replacement product with high clotting factors that can help to control major hemorrhage. By transfusing FFP directly into his bloodstream, Catherine hopes it will counteract the effects of the blood thinners he's been taking and limit the amount he bleeds when she operates.
Can I have a suction tubing, please? Thank you.
Well, I've had 2 bags of crisps for lunch, so I'm good to go.
As it's a complicated case, senior consultant surgeon John Whiting has agreed to operate with Catherine.
2 failed liver kidney transplants.
The type 1 diabetic.
Yeah. And you've had a pancreas transplant.
Knife, please.
Big hole.
Well, somebody's been here before. Because of his surgery previously, everything is very stuck.
When you go into somebody who's had previous surgery, especially if they've had multiple previous surgeries, it's always a little bit nerve-wracking because you don't know what you're going to find.
I haven't met much blood yet. Well, I'll tell you one thing, it's completely stuck here.
It's a bit like a book. If you want to open the pages on a book, if the book's new, it's dead easy. Now imagine throwing that book into a bath and then drying it up. And so going into somebody who's had previous surgeries is like trying to separate all the pages.
Let's just see where I can get into here.
Sometimes things will be so stuck that actually you can't but rip pages.
Well, he's got blood in here, we're not making it up. Pass, please.
With the abdomen open, she fills the cavity with several large abdominal packs to temporarily control any bleeding.
You put the packs in, we call it damage control. A large dishcloth, sterile. They take up space, they absorb stuff, but it helps me give compression to stop hemorrhage and control contamination. Those are your 2 key things you're trying to do. If you have a basin ready, because then whatever clot we can get out, we can just put it straight into the basin.
The clots of blood confirm her suspicions of internal bleeding, but now she needs to locate the source.
Where is that coming from? Where is, because it's coming off a spleen or because...
Not an easy task in the body's largest cavity.
Opening somebody's tummy in trauma, you almost have a recipe in your head. You go through and you check everything from literally A to Z and make sure that there's nothing I've missed. And I do that like a clock face, and I do it the same way every time. So no matter how bad it is or how awful it is, I will methodically go through every organ, every junction, every zone. Let's just run this from the top. I start with the big organs, which are the spleen and the liver. So the big, what we call solid organs. And I'm starting to make mental notes. That's fine, that was clear, that's not clear. Okay, we've got this problem here.
8 digestive organs, including the small intestine, which alone can measure up to 20 feet in length, are housed within the abdomen.
This is going completely underneath here. I have to free this off.
Catherine has to track through every inch of it if she's going to find the bleed.
It's all your senses. You're listening, because sometimes you can literally hear bleeding. That's very sharpening. And you're looking. So, for example, the spleen. You run your hand over the top of the spleen. What you want is a lovely, smooth feeling. Scissors? Yeah. And the gut then is like a big long hose pipe, and you follow that big long hose pipe in all aspects. So you check all of those areas. So it gives you that sensation of, yep, everything feels fine. We're not in a hematoma that's so big in there here. I mean, he's got a tear there, and he's got a hematoma here.
So there's the hematoma, and you can see the tear.
Having searched his entire abdomen, Catherine finally finds the source of the bleed. A cut to Stephen's mesentery, the membrane that secures the intestine to the abdominal wall.
I mean, he's got that mesenteric hematoma, and he had some blood. Not as much in here that I would be thinking his blood pressure was in his boots because of what was in his belly.
Another mop, medium mop.
But the injury doesn't explain why Stephen's blood pressure had fallen so low.
Okay, so his left liver is completely intact. You're always questioning, am I doing the right thing? Have I made the right decision here? And I think the more time you have to think about decisions, the more that makes your doubt come in.
So, what have you found? Not a lot.
Not a lot. That's hematoma in the mesentery.
Oh, yes.
But that's A, not hosing, and B, not killing him. In some ways, we didn't have to do any actual interventions. But do I believe that I made the right decision to operate? Yes, I did.
Okay, let's have the closure suture, please. Thank you.
All right.
Satisfied there are no other internal injuries, they begin to close.
If I'd let him go any longer and he got sicker and something dreadful happened, you would look back and go, why didn't you operate at that point? What had happened was that he had had a big bleed initially when the injury first happened. And then his body just didn't have enough gumption, for a word, or enough strength to cope with that blood loss. So when I went in, my concern was he was still bleeding.
Yeah, that's fine.
Once we got all the medication in to stop the warfarin thinning his blood, actually that bleeding had stopped.
Okay, we're done. Thank you very much.
He's not the 20-year-old who's fit and healthy with no past medical history. You could almost say, should you really be riding a motorbike at, relatively high speeds? I'm sure it's great fun and the thrill of it and the sense of freedom and speed. But sadly, unfortunately, I just see the wrong side of the outcome.
The fractures in Stephen's left arm will still require surgery once he's well enough, but for now, he'll be taken to intensive care and stabilised.
I'm very happy I found what I did because it meant that I knew he was going to recover.
Tidy up. We're not stopping for a break or anything silly like that.
Between each life-saving trauma operation, the theatres must be cleaned and prepared, ready for the next case. Everything used while Stephen was in theatre must now be removed for cleaning. Each emergency theatre at the QE has trays of specialist instruments on standby for life-saving procedures. It's vital that there's a fast turnaround system to keep them sterilised, ensuring they're always available for trauma cases. On the outskirts of Birmingham, Europe's second largest decontamination facility is responsible for collecting and cleaning used trays 24 hours a day, 7 days a week. When the trays arrive, they are checked in by hand and then fast-tracked through a 4-stage process.
We probably process in the region of 350, 400 trays per shift.
Everybody is aware that at the end of every single tray that we have, it's a patient.
Once checked in, the blooded instruments are cleaned and disinfected before being inspected, packed and sterilised. First, they are put through a multi-stage wash process, which includes thermal disinfection at a temperature of 90 degrees centigrade. Then they are released into a medical clean room, where the staff inspect every aspect of the instruments by hand.
They're tiny little clamps to use to stop a bleed in the patient at Queen Elizabeth. So I'm just checking to make sure there's no blood inside.
Around 1,500 trays go through this process every day.
And those trays can range from a few instruments to an instrument tray like this, which has 160 instruments on this one particular tray.
And every instrument is accounted for at every stage.
They obviously rely on us. Even if it's a small tray, I would like to get it right. It is very important.
After being cleaned, the instruments are packed and wrapped. To ensure they are sterile, the trays are then subjected to the final stage of the process, a 1-hour steam sterilisation at a minimum temperature of 134 degrees. The turnaround time for returning decontaminated trays to the QE is usually 24 hours. But in emergency situations, they can be dealt with in as little as 5.
I always think that it could be one of my family members. It will save someone's life.
At the QE's emergency department, the trauma team on shift today have already treated patients from a car crash and a shooting.
Hello, QE.
The third trauma call of the day is on its way.
We have a trauma alert, another one, yeah?
A motorcyclist has collided with a car. British emergency departments treat around 18,000 motorcycle casualties a year, almost a third of them aged 17 to 24. This time the driver is just 18.
Where do you want to go?
We'll have 6.
Okay.
One of the first to respond in resus is trauma specialist JJ Lee, who will oversee this case from the start.
When I hear that I have an 18-year-old male, I'm not surprised. Our younger population, particularly men, are more active and probably more likely to take risks.
Ready, steady, then.
So this is Jamie. He's 18 years old, was the rider of a moped. There's been a car turning right across him and essentially T-boned him and then thrown him about 15 to 20 foot off his moped.
The patient, Jamie, appears to have serious injuries affecting his right leg, from his foot up to his pelvis.
I know as a young person he has a lot of reserve so that he is strong and probably the fittest he's going to be in his life. CT's ready when you are. But he's able to mask signs of significant chest deterioration, any abdominal injuries, solid organ injuries. And so I want to get this patient to the CT scanner now.
The scan confirms that while Jamie has no hidden injuries, he has broken the 2 longest bones in the human body.
So it looks like we've got right proximal femur fracture and right tibial fracture. Okay, that's the hot report.
Jamie's broken the large bone in his thigh, the femur, and the tibia in his shin.
Jamie, my name's JJ Lee. I'm one of the trauma surgeons. How are you feeling? Are you in pain?
Just that leg.
Just the leg. What Sid needs to do is just to put a little probe onto your foot just to see if we can check the blood supply of that foot, just to make sure it's okay.
Hang on,
All right.
does it softly? I don't care.
I'll ask him nicely. You've got to be nice and do it softly.
Try and be as gentle
That's
as
what
I
Jamie
could,
says, okay? You've got family members here. Do you want to see them?
Yeah.
You better see Mum first, I think. Yeah? All right. I'm going to go and get his mum. So Jamie has significant lower limb injuries, but actually those bones are so broken that they're going to need surgery. But the surgery itself can be quite traumatic, almost the same as being injured again. And it's that shock and expectation of what we're going to need to do that I need to manage, not only for him, but also for his family as well. We will stabilise his limb and then for theatre tomorrow. Yeah.
Jamie recently started work as a pub barman, his first full-time job after leaving school.
He rang me at 7 o'clock and all he kept saying is, "Mum, help me, Mum, help me. Mum, come and help me." This could set him back 12, 18 months. Just like to keep me on my toes, don't they? I'll see you in a bit, love ya. Normally I'm quite strong, I'm not normally weak. He loves his job, he absolutely adores his job, and not being even just to be able to go there will be heartbreaking for him.
Jamie's operation is expected to take up to 4 hours in orthopedic theatre number 1, dedicated to surgery on the muscles and bones.
Ready, steady, slide. There we go.
It's probably a rugby player.
Well, let's hope he supports a good team.
Consultant orthopedic and trauma surgeon Ravichandran Karthikeyan, known as Karthik, will carry out the procedure on Jamie's badly broken leg.
Fixing broken bones is something that we do day in and day out. We roughly treat between 2,000 and 3,000 people a year. There's an operation straight down where we want to go, isn't it? That's typical tuberosity. Of course, there are complications from these operations. Wounds can get infected. The metal itself can get infected. Worst case scenario could even be a risk to life. Okay, just mind yourself, guys. X-rays coming in. Okay, that looks good.
Jamie has fractures in both his femur and his tibia. Karthik will make an incision in the front of Jamie's knee. He'll need to realign the broken bones before inserting 2 titanium rods into the upper leg and then into the shin. The rods will be secured by 8 locking screws.
Other plan is I've discussed with Alex as well earlier on. If there is any problem during the femur or after the femur, we'll cut short and then put an X-fix and get out. Is that all right?
The team will operate first on Jamie's femur. If he remains stable, they will continue with the second procedure on his tibia.
Okay, have skin knife, please, thanks.
Karthik makes an entry incision in the knee.
You're entering through a pristine knee joint. So you want this knee joint to be pristine for the rest of his life. You have to make sure that you don't cause any more splintering of the bone. So can I have the entry guide wire, please?
First, he'll need to drive a guide wire up through the bone and into the marrow-filled canal in Jamie's femur.
Oh, it's midline. That's pretty much where we want to be.
As well as creating a pathway for the titanium rod, Karthik will use the wire to help realign the fractured femur, as he needs to manipulate the broken sections of bone back into position.
Okay, can I have the driver, please, now? In Jamie's case, he's got a very tough bone. And actually treating someone who is younger makes it a little bit more difficult because the bones are much harder. And again, Tim. Can the screen come a bit closer, please? Hang on, sir.
Karthik continually checks X-rays to monitor the progress of the wire inside the displaced femur.
Yeah, that's much better.
Yeah.
And again? Good, Dan.
It's got solid bone.
When you're drilling into an elderly patient's bone, it's pretty much like cheese compared to drilling into granite on a young person's bone. You can get tired pretty quickly.
That's your workout for the week.
Yep. I don't think you need to go to the gym after this, but just lift the tibia a little bit up so I can get in a little bit more angle. Then I've got it.
With the guide wire deep inside the femur, now Karthik needs to work against Jamie's leg muscles to maneuver the broken bone back into alignment or reduce the fracture.
Can I have the reducer, please, instrument? Jamie, he's a young, fit individual, and his muscles are going to be strong compared to someone who's much older, and you can actually overcome these forces a bit more easily. Tim, show us that, please. Can I have a mallet wrapped up in a swab?
With the bones still out of line, now Karthik tries applying force to the outside of the leg.
And then show me that, please, thanks. And again. So I need to be up. And again. It's completely defunctioned, so. And that gives you a bit of extra traction. And again, please. I have to constantly keep thinking in my mind, am I going to take a longer period of time? Is he going to tolerate that longer period of time?
If Karthik can't maneuver the broken sections of bone into alignment, he will have to apply more direct force to the fracture by making an incision deep in Jamie's thigh.
When you're thinking about having to use a second incision, it's causing more trauma, which can then lead to a delay in healing. or even might lead to not healing completely.
Okay, so I know it's not aligned in the AP plane. And again?
So that kind of decision has to be made pretty quickly because you don't want to spend too much time on the operating table.
It's not playing ball. Okay, relax, let go. All right, we'll better open it up and then nail it. About there. Skinny knife, thanks.
Karthik's best option now is to cut into Jamie's thigh, as close to the fracture site as possible.
So feel that, so you can get the fracture, you can feel it.
Oh yeah.
The femur is one of the biggest bones in the body, so if you want to control it, you need instruments that are big enough to control it as well.
Okay, hair grooves again, please, thanks.
With forceps, he grasps Jamie's femur to try and pull the broken sections into position.
And again. Okay, and again.
You have to use force, physical force, to actually reduce the fracture fragments together. And there's no easy way around this.
And again, please.
It's not just brute force and ignorance, it's actually a technique involved. You have to make sure that none of the other soft tissue structures are caught in it. My worry would be damage to nerves and blood vessels, leading to a loss of limb in a worst case scenario.
And again, Tim. Okay, that's nearly there. And again. That's passing through. Okay, so that's the tricky bit done. It's a bit of hard work.
With the bones finally in position, the team can now push the guide wire into the upper section of the femur.
Show me that, please, Tim.
And insert the titanium rod over the wire so it slots neatly into place.
Tim shows up.
Ultimately, the bone will heal around this rod. The bone will then take over the function and the rod will be then defunct.
With the rod in place, the guide wire can be removed and screws lock the rod in position.
Right, next step down.
Jamie's thigh bone has been repaired. He's been in surgery for 2 hours.
Now start thinking about whether he can tolerate another couple of hours on the operating table to fix his tibia. I discussed with the anaesthetist to find out whether this is going to be feasible.
How's it feeling, Alex?
Doing great.
Okay, so should we proceed then?
Yes.
Okay.
This time, Karthik is able to drill down into the bone and feed the guide wire through the fractured tibia without additional incisions.
Suction, please. But we should be able to stop there because I don't want any more deeper there.
The screws secure the rod in place.
It's definitely there, isn't it? Yeah. Okay.
After 4 hours of surgery, the fractures are now both permanently stabilized.
That's nearly done. All done. Happy?
He's just over the first hurdle at this stage.
It's all done.
Then he's going through the next phase of rehabilitation, which is to mobilize him. I would definitely look forward to him walking independently and mobilizing, perhaps not on the motorbike.
Jamie will remain in hospital to recover and start the rehabilitation his leg needs. It's been 2 days since Stephen came off his motorbike and he's back in theatre. He's about to undergo extensive surgery on his left arm.
Okay, ready to start?
Yes, please. That's good. Thank you.
The force of the accident shattered the long bone in Stephen's upper arm, the humerus, in 3 places.
So that and that should be together. And try to bring them together and fix them together with a couple of screws.
The bones are pulled together and secured using a 27-centimetre metal plate and 13 screws.
There's a cat with 9 lives. He's used up a few of them. Life throws many things at us and rolls many die. Stephen is very lucky. He has had a serious injury which will affect both of his arms. So to recover from that, is not insignificant.
Okay, I'm quite happy with that. Thanks, guys.
Ready, steady, slide.
For 2 weeks, Stephen recovers in hospital.
Critical care area, was I in there?
Yeah, he was in there.
Today, he's finally on his way home.
I've come off at over 100 mile an hour and I've just done nothing. And yet this was 40, 50 mile an hour and nearly died through it. I don't bounce as well as I used to. Physically, I'm nearly there. Mentally, it's still affecting me. More wary of things that can happen. Surgeons have saved my life. They just say it's a job, but they save lives all day long, don't they? I've been lucky, very lucky. It's incredible.
25 days on from his accident, Jamie is well enough for his mum to take him home.
Put an engine on this eventually.
Jamie's always been a happy-go-lucky boy, and I just want him to go on being active, being happy.
Six weeks after falling in the street, Susan is back at the QE.
If they hadn't have operated, I would have been a goner.
Although physically she has made a good recovery, the injury to her brain has affected her memory.
How are you?
I'm very well. It's the best day since I come out of hospital.
When you were admitted, what was your first proper memory of in hospital? Not what other people have told you.
Because the surgeons came up to see me and they just came to have a look at me, see if I was okay, and just reassured me. Really, really nice guys.
How long after the accident do you think that was?
I don't know, probably the next day.
No, I think it was actually a few weeks later.
Really? Honestly? Could have sworn it was the day after.
Well, at least you did remember being here, so that's good.
She doesn't remember me at all, as I would expect. So the last time I saw her, she had no idea who I was, no idea what I'd done. That's to be expected.
That's healed really well.
Sometimes you'll see patients who have been very, very dependent for weeks, months on the ward, and then you see them in clinic maybe 6 months, a year down the line, and they're completely transformed. That makes it worthwhile.
While Susan's memory has been affected, there is now every chance that she will make a full recovery.
Thank you. Lovely to see you.
You take care.
I will do. And you.
See you soon.
But she was lucky. She was found quickly, transported here quickly, scanned very, very quickly, and straight into theatre. Could have been a very different outcome. But there's an old boss of mine who used to say, it's better to be lucky than good. So yeah, I do believe in luck.